Okay, the webinar is live now, so we can see participants coming in.
Shall we make a start?
No, can you guys see the participant list? No. Is
No.
it? Oh, all right. Maybe just wait for a while. Now we have 21.
Yeah, we can see, yeah.
You can see, right? Okay. We give us a couple of minutes. I'm still seeing people coming in.
Okay, I think we can make a start. Very good afternoon to everyone, and thank you all for taking time out to join us in this webinar titled Competency-based Medical Education and Introduction to CyberPatient. I'm Olivia, I'm the host for this session, and I'm from iGroup. iGroup is a one-stop station for information products and library technologies. Our ability to provide a full spectrum of related products and services with localized support from each of our regional offices has established us as the key information industry partner in the Asia-Pacific region. For today's session, we are going to have two parts to it. First of all, we will have an introduction to CyberPatient, which is an e-learning platform by two of our team members from CyberPatient. As you can see here, Mark and Nikki. Mark is the Director of Business Development from CyberPatient, and Nikki is the Customer Support and Institutional Onboarding person in charge, also from CyberPatient. So they are going to give us an introduction to CyberPatient and then followed by a talk by Professor Dr. Karim Kayomi. So allow me to introduce Dr. Kayomi briefly before I hand the floor over to Mark and Nikki. Professor Dr. Kayomi is a professor of surgery at the University of British Columbia, and he is the founder of the UBC Center of Excellence for Simulation Education and Innovation. He's also the Padzold Chair of the Technology-Enabled Learning for Vancouver Coastal Health and Regional Director of the Royal College of Physicians and Surgeons of Canada. Dr. Kayomi is the President and CEO of Interactive Health International, a software development company that creates medical education software. He is also the founder and CEO of Can Health International, a registered Canadian nonprofit charity that aims to equalize health education between the developed and developing countries using the state-of-the-art technology. Professor Dr. Kayomi has extensive international teaching experience with excellent records obtaining 11 awards in the field of medicine, including the most prestigious award from the University of British Columbia in 1999. He has completed a variety of research projects. Recently, his focus is on technology-related research and innovation. Amongst his patents and innovations, there is the development of technologies such as an online learning management system called the Electronic Platform for Education and Research, as well as other things like robotics for tele-home care and patient-centered medical records. So at the end of this whole session, everyone, all the participants are encouraged to either type in the chat or unmute yourself to raise any questions or give any comments that you may have. So without further ado, I would like to hand the floor over to Mark and Nikki to walk us through CyberPatient. Over to you, Mark.
Hi, good morning, good afternoon. Thank you so much, Dr. Olivia. I really appreciate it. As mentioned, my name is Mark Ritchie. I head the business development here in Vancouver at Interactive Health International. Our flagship product, which is CyberPatient 2.5, which we're going to share with you today. We're really excited about it, and we're also really excited as a launch of a partnership with iGroup in the Asia Pacific region. And thank you, Nikki, for joining me today. She's also in Vancouver, and Dr. Kayomi is joining us as well. So I'm going to share my screen, and what we're going to do is we're going to just give you a very high-level overview of CyberPatient. We're going to take you into the faculty dashboard. We're going to talk about the assessment, so formative feedback, summative assessment for students. Then we're also going to take you into the student dashboard, and then we'll complete kind of a sample class with a summative assessment and formative feedback. So I'm going to bring you in now, and you should be able to see my screen. I'm just going to share my, start the deck here. All right. All right, perfect. So CyberPatient, we really like to kind of say that, CyberPatient bridges the gap. The major problem that we see is the gap between the theory and the practice of medicine. And so CyberPatient was built and is an intended technology tool, which is going to allow students to take the theory that they're learning and to instantly apply that into practice.
The gap between theory and practice of medicine is well established and has been known for a long time in medical education circles. With the help of technology, we can close this gap with virtual environment. I personally felt that when I was a student. And the first time I entered the ER, I right away realized that the books and lectures did not prepare me for real life. Now we have CyberPatient. CyberPatient is a virtual hospital with 130 digitally enhanced patients that their students can use 24/7 and as many times as they want.
CyberPatient is the ultimate tool to support students, build confidence, and enhance the development of clinical competencies, no matter where they are in the world.
Perfect. So actually, as Olivia had mentioned, Dr. Kiyumi, he is still a professor of surgery at the University of British Columbia. And one thing that's beautiful about CyberPatient is that CyberPatient was not built by technologists, it was built by faculty and the leading pedagogues here in North America, also built at the UBC. So we are a UBC spinoff. And really what CyberPatient brings to the table is a safe virtual training hospital on demand 24/7. It's a competency-based platform, which allows students to really learn at their own pace, but also important for faculty when looking at competency-based education is the formative assessment and the summative assessment, so that you can actually measure the skills and the competencies that are being developed by those students. Now, this virtual hospital that we bring has 130 virtual patients available. They're peer-reviewed. There's a mix of both inpatient and outpatient cases, covering currently 13 different systems and specialities. And we're also continuing to grow that. You will see inside of the platform today that there are thousands of diagnostic and animated assets. And it's also quite unique in the approach that, CyberPatient really doesn't just focus on a specific point of care, but it takes the students through the full continuum of care. It is a very flexible technology. Although it was built intentionally for undergrad medical education, we also see it being used in nursing programs, undergrad nursing, nurse practitioner programs, also PharmD, which is using it for patient assessment. So there's a lot of different ways that CyberPatient can be utilized. Inside of the platform provided by UBC is also 750 educational resources. Nikki's going to highlight those resources towards the end of her presentation. So that's really great content. These are videos, lectures, webinars that your students and your faculty can take full advantage of. Also, I kind of like to highlight that CyberPatient is really a textbook come to life. You will see that if your students are using textbooks similar to, say, Bates Guide for history taking physical examination, maybe Moby's, for example, Maclean's, you will see a very fine alignment with what the students are learning in text and theory, and instantly have the technology to put that into practice, which is going to really help support the pedagogy of CyberPatient, where it supports the memory retention, recall recognition. So instantly having technology to put into practice. So as Dr. Kiyumi mentions, and he's going to talk about this in his lecture as well this afternoon, is that CyberPatient was not designed to replace theoretical knowledge, physical clinical skills, or standardized patient programs, but a supportive tool to help students go through the first 3 stages of the 4 stages of learning, which is the introduction, coaching, and fine-tuning, designed to enhance compiled thinking and recall recognition while using visual, tactile, and written memory in a safe virtual environment. The platform is very flexible in how you utilize it into your curriculum. Some use it for student remediation, some people use it for virtual rotations, some use it for mini OSCEs, virtual OSCEs. many different use cases for the technology. We will share out these expert series following today's session. These are an expert series that Dr. Kayumi had done, fundamental theories behind education, competency-based education, curriculum development, and gamification in education. Fantastic pieces of content that I believe your faculty and yourselves will be able to gain great knowledge from. Now let's talk about the cases on the platform and how how they're set up and the design and the function of them. So as I mentioned, there are 130 cases on the platform. They're broken down into 4 different skill levels. Any case can be used on any of these 4 different skill levels. Level 1 is more or less for your novice, your introduction, pre-clerkship. It only covers history taking. Level 2, again, more intended for novice, pre-clerkship, supporting the physical examination. And what the students will be able to do after they've completed the history taking physical examination, they're going to be able to take all of that information and prepare a provisional diagnosis. Level 3 and level 4 cover the complete continuum of care. However, on level 3, after 3 consecutive mistakes, it will push the student to the next stage of care. On level 4, it will reset the case. So very minimal errors can be allowed on level 4. Now the structure of the cases, you'll notice takes a very fine structure here, looking at level 1, history taking, physical exam, moving into the investigation and analysis, the planning, the case management, the diagnosis and the treatment, the review of the diagnosis, next steps, follow up the case and the closure, and then the medical records updated. So a lot of opportunities for students here to learn, to practice clinical decision-making as well. On the medical records update, great use case for students to practice documentation. We know that a lot of medical errors take place due to incorrect documentation and handoff. So great exercises could be done there. Time and cost awareness is also a factor for students. So it also shows the students that, if they are running incorrect investigations and tests on their virtual patients, it will have an impact on the healthcare system, regardless if it's private or public. So just to make them aware. Now, where do we see CyberPatient fitting in, supporting the learning journey? As mentioned, CyberPatient was built as a stepwise progression platform. So it really is intended to support all years of medical education. And we can look at from the preclinical textbook alignment, very fine textbook alignment, even a preparation into a simulated environment. It can be used as problem-based for case-based learning. It can be used as an introduction to a clinical environment, preparation for clerkship or internship as well, all while focusing on competency-based education. Now, what's important in this competency-based education, as we know, if you're familiar with Kolbe's learning cycle, is, learning, taking action, and then of course, the assessment is extremely important. Now, the important part of the assessment is the self-assessment. So CyberPatient has an intelligent tutoring system built in. It's going to notify the students where they've made mistakes, where they've had some challenges, and where they need to improve. And also for the faculty to provide assessment for the students. So that can be done through a formative feedback. And so they're going to be able to see the dashboards, identify the students' rationale. They're going to be able to provide detailed documentation and communication with that student and help them to expand and grow their knowledge. The way that we would expect to see those students respond is by working on those cases again. At the end of a course, we will complete a course with a summative assessment. And then also another use case for CyberPatient, as I mentioned, is for online OSCE exams, a fantastic way that the platform can be utilized. One of the things we'll talk about as well, just very briefly, is that CyberPatient has 130 cases on the platform. These are pretty much the most common cases that you would see globally. However, we do recognize in Asia Pacific there are going to be cases that you may need, for example, tropical diseases, for example. We do not have any on there, but this is an area of collaboration, an area of support that we can work and we can partner together. So all of our cases, they go through a case creation, they go through a peer review process. We can make cases, we can put them through your peer reviewed committee, as well as our global education committee. And then we go through testing and publishing. And as a partner, you'd be welcome to use this case that we've created, just as you would any other published paper, for example. The research, there's a lot of research that has been done with CyberPatient. And of course, as a very innovative technology, there's also continued to be a lot of additional research that can be done. Much of our research consistently shows that it's more effective than text-only learning for physical examinations. We consistently see that average and weaker students perform substantially better on their OSCE exams. We also see that the cost benefits for CyberPatient are great. For example, in North America here at UBC, the study was done. There's a 90% savings on the standardized patient program when using CyberPatient. And I'm going to let Dr. Kayumi, he's going to speak about that as well towards the end of his lecture as well. We will share out these research papers with you, so I'll make sure I coordinate that with Dr. Olivia and the iGroup team. So again, number 1 is from UBC. Number 3 is actually from Kochi University in Japan. CyberPatient is more effective than text-only learning for physical examination. Weaker and average students perform better on OSCE exams. There's research papers from Kazan State Medical University. And then also, of course, here from Karolinska Institute in Sweden, talking about the undergraduate nursing program as well. So without any delay, I'm going to take you into the CyberPatient platform. I'm going to bring you in as if I was a professor. And Nikki is going to join me in a moment, and Nikki is going to show you the role of a student. So I'm going to log in here. And basically what we're going to do, the first thing you'll notice on the left-hand side, we're going to click on settings. You'll have a general settings here where you can adjust your first name, your last name, your title. This will be used on the summative assessment, on the certificate. You also have your skill set settings. So as I mentioned, 4 skill levels are available. Level 1, history taking. Level 2, history plus physical exam. Level 3 and level 4 cover the complete continuum of care. So I'm going to click on case library and turn on the dashboard, I apologize. And I'm going to create a class for today. So we're just going to create a class name. And we're just going to call it iGroup, CyberPatient Introduction, and Introduction to CyberPatient. We're going to enter a course period. So if you'd like to have a course run, maybe a 1 day for mini OSCE exams, if you want to run it a full week, maybe you're running a special 1-week course on pediatrics, or you want to run it a full semester, you have that flexibility for the course period. Set up your faculty name. You're going to choose your skill level, and you're going to choose a required passing percentage. On the right-hand side here, we have a criteria for our course or for our class. We have a default criteria already built in, or you can go and you can actually create your own custom summative assessment criteria, which would have different percentages based on what your course is. For today, we're going to use the default. So we're going to say 4 points at 25% each. So the student completed all of their assignments. The student responded to the feedback and worked to improve the clinical skills, clinical reasoning, and critical thinking. The student reached the required level of performance, and the student has had a good overall attitude towards the online education environment. So we're going to click on complete. Now what we need to do is we need to add students. Now for the classes, you can add as many students as you would like to a class. as well as for the cases. So when we open up the case library, you're going to see the different systems that are available. You have CNS, cardiac, ENT, gastrointestinal, genitourinary, musculoskeletal, neoplasms, OBGYN, pediatrics, psychiatry, respirology, and surgery. So what you're going to see if you click on see more, you'll see the case library expand. And as I mentioned, there's 130 cases here. You're going to see the name of the patient as a faculty member. You'll see the diagnosis of the patient, and you're going to see the learning objectives. Every case has unique learning objectives that are aligned with the LMCC, which is the Licensing Medical Council of Canada. So these are actual licensing learning objectives that are from the LMCC. So here we have given a patient with chronic abdominal pain, the candidate will, 1, 2, 3. If you wanted to look at another case where it says like Mary Washington, upper GI bleeding, given a patient with upper gastrointestinal bleeding, the candidate will, again, 1, 2, 3. And so very clearly defined learning objectives. So as a faculty, you're going to go and you're going to look at the case that you're looking for. You're going to look at the learning objectives, make sure they align with your learning outcomes that are required. And I'm going to go ahead and I'm going to add these cases onto the system. And this will actually create our class. So our class is ready to be utilized by Nikki. She's going to join in now, and she's going to walk us through the student experience.
Thank you, Mark. Hi, everyone. My name is Nikki Zavatsky, and I will be walking you through the student experience, and first starting off with the student dashboard. So I'll start by logging in here, and we can see the skill level that I'm set to, as well as a summary of my last case performance. Additionally, I can see the class that Mark has just set. I can open up our class here and see the parameters that Mark has set prior. So I see the skill level, the required passing percentage, my course performance summary. So if I've completed a case during this, it will have updated with my grades. And I can go and perform and open up a case. First, I see some feedback. So if there was feedback left from me prior, in the example here, I can see what my professor has left for me based on a prior attempt. So let's start with today's case. I will open up the patient, and I can see an overview of his profile. I also, if I need any refreshers before beginning, I can click and have a tutorial on each section of the case. Now, before we proceed, I would like to note that I do not have a medical or nursing background, so please do not worry, I will not be treating a real patient anytime soon. Now let's get started.
Hello, I'm Dr. Smith. I'm the on-call doctor today.
Hello, Dr. Smith.
Okay, every case begins with history taking. First, I can translate the interface up here into 72 different languages. I also have my patient chart, which I will fill in with my findings and reasoning, and there are some tips here for beginner chart takers. We have our help button. By clicking on the help button, I'm prompted to watch a tutorial on this section, and there are some FAQs. Now, if we get back to the case, so our history taking is structured with categories for the questions. So we have patient information, chief complaint, history of present illness, and so forth. And these questions are structured based on textbook's classic way of teaching history taking. Like Mark talked about before, at CyberPatient, we bring the textbook to life. And so I can go in here and click to ask a question.
What is your name and age?
My name is Jeremy Ramsey and I am 37 years old.
I can go into chief complaint.
What seems to be the problem today?
I have heartburn and burning pain in my lower chest.
And these questions are scored based on relevancy. So if I ask a question that is less relevant to the case, for example,
How is your financial situation?
Good.
We'll see at the end that this is less relevant. And navigating through these categories is directed towards beginner students, but as I advance, I can search for a question directly here.
Do you eat spicy food?
Yes, I love spicy food.
Or,
Does alcohol make the pain worse?
Yes, it does.
and I would like to add, in addition to our question categories and searching for questions, very soon we'll be implementing a new feature with AI and natural language processing, where I'll be able to speak to Jeremy and ask these questions and have a conversation like we're having right now. We do have around 150 to 200 questions available per case. For the interest of time, I will not go through them all today, but what I will do is fill in my patient chart. I'll add in the chief complaint and then my hypothesis. And as I fill in my chart, not only will I as a student have access to this at the end, but so will my faculty member. Now I will save and close and finish patient history.
Thanks for the information. At this time, I would like to do physical examination. Please let me know if you feel uncomfortable. I will wash my hands before we start.
Now on to physical examination. This section is based on experiential learning, so learning by doing. And we can see that here as I have to perform these exams manually, which is an opportunity that textbooks don't provide, and allows me to practice these exams on a virtual patient before ever treating a real patient. And this is when we talk about bridging that gap between the theory and practice of medicine. So with our exams, we have general exams and special exams. General exams have three components: vitals, methods of examination, and diagnostic instruments. So I can first start by taking Jeremy's pulse.
Please give me your wrist so that I may check your pulse.
I will start and stop the clock and count the pulse to the right. Then I can go into blood pressure.
Please put your arm in this cuff so I can check your blood pressure.
I can pump the manometer and then release the pressure. From here, I will determine the systolic and diastolic pressures. I can also zoom into specific areas.
I'm going to take a closer look at your head.
I am prompted to use tools such as the speculum,
Please tilt your head up so I may use this speculum.
tongue depressor,
Please let me use this tongue depressor to examine your mouth.
an otoscope,
Please sit still so I can use an otoscope to examine your ears.
and lastly, the ophthalmoscope.
Please look into the light on the ophthalmoscope.
And if there are any pathological changes here, this would be displayed in Jeremy's imagery. I can zoom into his chest
I'm going to take a closer look at your torso.
and perform an auscultation.
I will use my stethoscope to examine you.
The clue button can be used to know where to place the stethoscope. And now I will hold and listen. We can rotate Jeremy around
Please turn. Please turn.
and continue to listen.
I will use my stethoscope to examine you.
Or the bronchial sounds here. And I can perform percussion.
I will inspect you by performing further examination.
Notice the resonant and dullness sounds featured. I'll lie the patient down,
Please lay down.
listen to his stomach,
I will use my stethoscope to examine you.
and we can perform a superficial palpation.
I will investigate using my hands. Please let me know if you feel uncomfortable.
Before going in for a deep palpation.
I will investigate using a little more pressure. Please let me know if you feel any pain.
And once we've completed with general exams, we can move on to special exams. For this section, we provide animation, and students are able to navigate through the categories to find an exam. So we'll go and perform a palpation of the spleen.
I am going to palpate your abdomen for your spleen. Let me know if you feel any pain. Please take a deep breath. Please take a deep breath. Spleen is not palpable.
And I can also search directly for exams as well. So I'll perform a Murphy sign.
I'm going to check your gallbladder. Please let me know if you feel any pain. Please take a deep breath in. Murphy test is negative.
And once we've completed with the physical exam, I'd fill in my patient chart. For the interest of time, we won't do that today.
After examining your patient, do you believe they require any immediate care?
And now, as Mark mentioned before, every case can be scaled to 4 levels. We've just surpassed where level 1 and level 2 would end off at. And this is where level 3 and 4 carry on to, where we get into the full continuum of care and the decision making begins. So Jeremy does not need any immediate care today.
What is your provisional diagnosis?
And I would refer back to my original hypothesis and select 3 conditions. Now, if I make an error, I'll be prompted with this message.
Incorrect. Please try again.
And I'm given a chance to redeem myself.
Please select the lab test that you require.
Now on to investigations. Once again, students can navigate through categories to select an exam. And let's perform a CBC. I can select on a specific row for the value to show. So for example, white blood cells. Or I can select all for a full panel. I can search for tests directly too. So let's perform an X-ray of the chest. Findings and impression will be found on the left, and I can click to expand the scan. Let's perform one more exam here and do an ultrasound of the whole abdomen. Report on the left, and click to expand the scan. And let's hit submit.
What is your final diagnosis?
We can confirm that Jeremy has gastroreflux.
What would be your management plan for this patient?
And we now transition into the management and treatment plan. So this will be non-invasive.
That's correct. How would you like to proceed?
We will send Jeremy home and with some at-home orders. So he can be active as tolerated. Diet will be non-MPO and diet as tolerated. We can also choose some recommendations. So searching by keyword, I can say elevate the head of the bed, limit spicy food, and avoid large meals. We can refer a team to further support Jeremy here. So I will also refer a dietitian. And now on to medications. We have around 5,000 medications available on the CyberPatient platform. I will first search and select the name of the medication with the appropriate strength. Choose a frequency of once a day and for a duration of 28 days. I can also leave some instructions to take with 8 ounces of water. Now on CyberPatient, we have the North American trade names, and we also have a World Health Organization's ATC classification, which is found in this row here. And we'll hit submit. And lastly, Jeremy can meet with his primary care provider in about 1 month.
You are ready to go home now. We wish you a speedy recovery.
And congratulations, we have just finished our first CyberPatient case altogether. Thank you for joining us today. And as you can see, the intelligent tutoring system has automatically calculated my score based on 3 indicators: the knowledge, time, and the cost of care. And these indicators are broken down into each section as well. So if we go into history taking, I can see that knowledge score, the cost, and the total time. By clicking on feedback, I can see the exact choices that I made, including their choices scored on relevancy. So I did quite poor on this section because I only asked 3 most relevant questions. and asking about the financial situation was less relevant. Now what I would do as a student, I would turn to my right and I'd study the most relevant choices, learn from them, and know to ask in my next attempt. If we go into diagnosis, I can see on the provisional diagnosis I only got 50%. By clicking on feedback, I can see that I incorrectly selected colon cancer and during the provisional. But by the time of the final diagnosis, I was able to learn from my mistakes and correctly diagnose Jeremy. We also have the patient chart, which has been saved as I went throughout, and I can export this or print it out. Now, the reason this intelligent tutoring system is an asset to students is because it can provide a detailed level of feedback that textbooks can't provide, and this detailed level of personal feedback is not possible in a clinical setting, as resources are often limited. And so before I pass it back over to Mark to show you the faculty dashboard once again, I want to show you our educational resources. So this is an additional feature that all users of CyberPatient have access to, and these are around 750 curriculum modules that are interactive and have fully animated web objects. We have modules on surgery, history taking and physical examination, and plenty more. So if I open up one of our resources here as an example, we can see the examination of the thorax and lungs. There is a variety of text and learning objectives that I can refer to. And as I scroll down to one of our animations, all of these resources are provided by the University of British Columbia here in Vancouver, Canada. And as we get to one of our animations,
crackles can be heard during inspiration or expiration. Fine crackles can be caused by collapsed alveoli popping open during inspiration and may clear with deep breathing.
And that has been the student experience. Thank you for your time. I'll pass it back over to Mark.
Hey, thank you, Nikki. Appreciate that. So just to wrap up a course here, typically what we would have is we would have the faculty would open up a class. They would see the classroom performance. They would see the student list. And so we would just open it up. We would see the name of the patient, the completion date, the score, and then we would also see the performance levels of the student based on their performance here. So we click on feedback, we open it up, click on see details, and we'll be able to see again the same dashboard that the student would have seen. Again, identifying the history taking, identifying physical examination, and all of the clinical decision-making activities. One of the things that's really important here is the treatment and the management. Of course, these are great areas for formative feedback. And so if your institution has a slightly different gold standard, this is an area where you'd be able to support your students. So once you've gone through, you'll be able to provide a formative feedback, which would then be sent to the student. They'd be able to respond again by working on that case. Again, we would expect that students work on the cases, minimum 3 to 5 times. And when we complete a course, we finalize it with a summative assessment. And so if I open up a summative assessment from a class that was already completed, we would have our criteria here on the left, which we set at the beginning of the class. We would have the performance snapshot or overview of the student on the course. We would choose to either pass or to fail the student. Once the student has passed, a certificate would be drawn up, and this would then be pushed over to your dean's office, administrator's office, to the student, and it will be branded by your institution. So in a very short, high-level order, that's a very quick overview of the CyberPatient interface. I'm going to now invite Dr. Kayumi to speak for a few minutes on the competency-based education, and then we could jump right into some Q&As after that.
Thank you very much, Mark, for the clear introduction to CyberPatient, and also Nikki for showing us the student view of the very interactive history taking, as you have seen, physical examination with effective formative feedback and a very safe way for students to practice clinical skills. So now we will move on to see how CyberPatient is related to competency-based medical education. So Professor Dr. Kayumi, as I was saying, is a professor of surgery at the University of British Columbia and also the founder of the UBC Center of Excellence for Simulation Education and Innovation. Without further ado, we welcome Professor Dr. Kayumi to take the floor. Over to you, Doctor.
Thank you very much. Dear colleagues and friends, first of all, I would like to apologize for being late. I was caught up in another lecture at UBC campus, and by the time I got here, it is a little bit late. And also, I would like to cordially thank every one of you for being here and having an interest in virtual simulation with CyberPatient. So I know that you're very tired now. I don't know if I can entertain you better, but I will talk to you maybe very briefly about competency-based education. And therefore, I'm just gonna share my slides if possible. Can you see the slides?
Yes, we can. Yes, we can.
Great, thank you. So I think by the end of this small presentation I'm making, you will be familiar with some introductory notes on competency-based education. We will also be familiar with the theoretical origin of competency-based education and may understand the role of CyberPatient in competency-based education. So perhaps you're all pedagogues, doctors, you all understand that there are many methods, classical methods to teach medicine. That would include chalk and talk, like lectures and seminars and things like that, reading books, giving assignments, problem-based learning, case-based learning, online learning, self-directed learning, group discussion, mentorships, and others. But the most important one that we're going to concentrate today is related to clinical rotations or clinical teaching, which is mainly based on experiential learning. That is, the methods that are used for this would be mostly simulation, apprenticeship model of see one, do one, teach one, and also competency-based education. So by definition, competency-based education is a method that allows students to advance based on two important criteria. One, the ability to master a skill, and two is to do that on their own pace. And the European Union actually defines competency-based education different than apprenticeship model, but from my point of view, there is no difference. What European Union defines is that competency-based education is a combination of knowledge, skills, and attitude of a trade, while apprenticeship model is an on-job training to pass the skills of a trade from one professional generation to the other professional generation. They also call it performance-based learning. But if you look at the competency-based education entirely, historically, competency-based education is not new as an apprenticeship model. You see here Dr. Shashruta of Banaras who lived about 600 years before Christian, and he was an outstanding surgeon. He wrote a book it's called Shashruta Samahita. If you have time, please go and read it. And in this book, he has described many surgical instruments and surgical procedures that are used even today by some modifications. So Shashruta was a very good teacher, and his method was the apprenticeship model. So as you can see in this picture, he was teaching students bedside teaching, and the youngsters are around him. So he doesn't just teach the skills, the students would also copy his attitude toward patients and attitude toward each other. And also he's passing the knowledge by writing a book 600 years before Christian. So to say that apprenticeship model is not a combination of knowledge, skills, and attitude, it has always been a combination of knowledge, skills, and attitude. So, the apprenticeship model have evolved from ancient time to the Middle Ages and coming back to the modern time. That's called now competency-based education. But in a modern time, competency-based education was very much practiced in the Russia, in other communist countries at that time, before the 1950s, after the Second World War. And in the United States, in Canada, our education were more based on university education rather than vocational skills and competencies. And this picture, as you can see, it's the first Russian Sputnik that went in 1957 around the orbit. And it made Americans very, very mad. And so that they put the Congress together, and both houses of the Congress got together, and they asked the questions, what the Russians have that we don't have. So the answer was very clear. The first thing is that the Russians are spending enormous amount of money on the development of technology. And the second was that the method of education that the Russians are used is not university-based, it's more competency-based and in vocational skill training. And therefore, Kennedy himself actually went into the specific committees, and Congress of the United States released enormous amount of money to develop technology. And as a result of that, the internet, what we are enjoying today, the www is developed because of that injection of that money after this Sputnik went to the orbit. And the second change that they made is that they made the vocational skill program very highly motivated in the United States, but also they made sure that even at the university level, people learn based on competencies rather than huge amount of theory. So now that we talked a little bit about the an introductory note about the competency-based education, we can now talk about theories behind the origin of competency-based education. Perhaps you all know that there are many theories in educational psychology, and that would include behaviorism, cognitivism, andragogy, style of learning, and many others. But the theories that are behind the competency-based education is two. It's constructivism and transfer of learning. We're gonna stay a little bit on those. The constructivism theory was proposed by Swiss famous pedagogue. His name was Piaget. So what Piaget said is that learning is secondary to and dependent upon progressive reorganization of cognitive function. To teach, Piaget said, is not to reshape behavior, but to provide the environment for students to self-explore. That's also called learning by doing or experiential learning. The other theory that is behind experiential learning is learning by experience is transfer of learning. So transfer of learning is actually not the same as transfer of knowledge, because transfer of knowledge is from one person to another person, and transfer of learning is from the same person to the same person. It's how our previous experience affects our next or future experiences that we're going to have. So this transfer theory was first recognized and described as a recognition memory by Hofding. So what Hofding was saying simply is that when we encounter a function, something to do, something that we experience, it goes through our sensory reception to our short-term memory, and then it goes to the long-term memory, to hippocampus, and there it forms a bunch of neurons in pathways would get together into a cluster that's called semantic network, and this semantic network is responsible to answer to the same type of question if next time it comes. So if next time we are encountering the same action, then we don't have to think, because the brain would realize that it relates to that semantic network, and it calls that semantic network and answers right away to the new event that's occurring that is similar to the previous event. And that's called identical theory or theoretical identical elements. But people have had question to Hofding. So what about if the prior encounter is not exactly the same as the secondary encounter? Does the brain or semantic neuron would react to that? And the question was yes. And they developed another theory is called cognitive theory of transfer. But what cognitive theory of transfer is saying is that if the second encounter should not be the same exactly as the first encounter, it could be similar to the first encounter, and then the brain would bring that semantic network and build around it to make it a new semantic network, particularly for this kind of encounters. In 1993, Chan actually described the stages of cognitive transfer. So what he was saying that there's 4 stages of cognitive transfer. The stage 1 is orientation. The stage 2 is coaching. Stage 3 is fine tuning, and stage 4 is solidification or routinization. So what it means, for example, if I gave you as a surgeon, when I teach my students knot tying technique, when I start teaching them, they know already how to do knot tying because their mothers show them how to do how to tie their shoelaces. So there's some kind of information is there with a semantic neural network that is responsible for knot tying, but it's not a sophisticated knot tying. So when I start teaching the surgical knot tying, so the first stages you see here, orientation, it calls that memory, and then the brain starts to attach new neurons and new pathways to that memory. After I coach them and take their hands and teach them how to do knot tying, and they learn, there are more neurons are coming in, more pathways are getting together. And then when they learn it, and then to fine tune that, they practice. And after that, you can see that some of those neurons would be gone, some of those pathways would be gone, some new pathways would be solidified. And then when they practice too many times, then the action is now solidified. And in this, if they see them in the OR, if a surgeon is doing like 100 knots per minute, it's because he doesn't think about it. It's recall, recognition, memory that supports him. So the problem we have in medical education, particularly in competency learning competencies, is that all these 4 stages of transfer occurs in the clinics with the real patients. And that makes competency-based education very expensive, very time-consuming, and at times it's very dangerous for patients. So now we can move on from this to how that would relate to a CyberPatient and a virtual simulation. Before we do that, I've just perhaps Mark and Nikki talked to you about it, but just to refresh your memory, what CyberPatient in my mind is a virtual hospital with 130 digitally enhanced patients that students can reach 24/7 and can practice as many times as they want with them, and without any legal or ethical consequences. And research I will show you later on has shown that it's much less expensive even than standardized patient. So before we go into the curriculum development for competency-based education, I would like you to touch base on the scientific management theory or task analysis. Scientific management theory was developed by Friedrich Taylor, and he was not actually a doctor. He was not a pedagogue. He was not a teacher. He was not even a scientist. He was an industrialist, a businessman. And the reason he developed the scientific management theory is because he was losing business and he didn't know whose fault is that. So what he did, he asked his workers, what's the biggest task you guys do? And they described him the biggest task. Then he divide that task into a smaller task and then divide it into a smaller task. And then each of those smaller tasks into another smaller task, to the point that he cannot divide that task any longer. And he called it the bottom denominator. He called it entry behavior point. So and then he assigned every entry behavior into one worker. So then he would know exactly whose fault is when the production is not moving forward. And the assembly line, in the production system is based on scientific management theory. In the, as I described before, after the 60s, when competency-based education was slowly flourishing in the United States, in the 80s, people start thinking, particularly in medical education, how they can use competency-based education and how they can use scientific management theory to develop curriculum for competency-based education. So what they did is actually very simple. The biggest, they identified the biggest task. The biggest task is the learning objective, or maybe the EPAs that we call entrustable professional activities. So what he was thinking, if we can take this learning objectives and divide it into smaller pieces, we get to the point that we cannot divide it anymore. And that entry behavior, we call it in medical education milestones. So APAs are the learning objectives, roughly, and milestones are the entry points in the process of task analysis. So coming from that now, we can now talk about how CyberPatient can relate to that. So if we have specific learning objectives in APA, or we call it entrustable professional activities, like history taking, physical examination, investigation, diagnosis, treatment, prognosis, and so on and so forth. Then every one of these would have a functional competencies. What is in there that would make this competency work? And that is to be able to read the vital signs, to be able to palpate, to be able to do the percussion, to be able to do the auscultation. And then you identify the specific milestones within the vital signs, within the palpation, within percussion, within auscultation, and the sum of those milestones then would support your competency-based education. Now, you can use CyberPatient in every aspect of the functional competencies or in the milestones. CyberPatient can also be used in the assessment milestones, assessment of functional competencies or assessment of EPA. So integration of CyberPatient into your competency-based education curriculum is very simple, and we will be more than happy to support you and help you if you need to do that. Coming back, to see how this relates to Chan's stages of transfer, what CyberPatient would do to make it better. So in our opinion, the first 3 stages of transfer, which is orientation, coaching, and fine-tuning, it all can be done out of the clinic in a laboratory condition, or better even in a virtual environment where you can have CyberPatient and use CyberPatient for all decision-making points, for all physical examination, history taking, every aspect of the curriculum that you can think of. And if you use CyberPatient or other simulators like physical simulators in the laboratory condition, and go through all these 3 stages of transfer, you can make the medical education less expensive. It will be faster, less time consuming, and it also supports patient safety. So you don't have to jeopardize a patient to learn knot tying technique on a surgical patient. You can teach them outside, and then you bring them into the clinic when they're ready for the clinic. So CyberPatient as a virtual environment does not replace the books, does not replace lectures, does not replace the physical simulation. It certainly does not replace clinical teaching, but what it does, it provides the environment for the students that after the students reads the books and listens to the lectures, it helped them to apply that theoretical knowledge into practice of medicine. So they get ready in the virtual environment much faster and better without harm to the patient and sooner before they go and touch a real patient. As you saw in the demo that you have seen, if a students go 3 times, 4 times over that patient, and then they go to ward, they would know exactly, oh, I don't need this. We don't need this medicine for this patient. We don't need to give blood to this patient. We need to just give saline to this patient. We need to keep this patient in the hospital. This patient can go home. So they can make a lot of important decisions in a virtual environment without harming a patient. And they practice that, solidify their knowledge, build those semantic networks in their hippocampus before they go and touch a real patient. So if you can tell me what are the pedagogical values of CyberPatient, is student-centered. Students can practice as much as they want on their own pace. It's competency-based. It's accommodating the style of learning. It improves decision-making abilities of students. It improves experiential learning. It improves compiled thinking, and also provide a solid base for transfer of learning. I'm just gonna, in the end, show you very briefly a few research projects that we have done. By the way, I have to tell you that with universities in hospitals that we have business collaboration and work, we support their research. And because CyberPatient is a disruptive technology, there is enormous opportunity for research. And all the research that I'm showing to you are done by other countries, by other universities, and not by us, but I have helped them to design the projects and to publish them. So this first project was done actually a long time ago in two universities in Jichi and Kochi in Japan, and it showed it was comparing the textbook learning to CyberPatient learning in physical examination, and it showed, as you can see here, that with CyberPatient, a student had an enormous, significant, better outcome. And also, it showed that students who are mediocre in low-grade students, lower achievers, they succeeded much more significantly than the higher achiever students. Because the 10% of higher achiever students, no matter if you gave them, they're smart and God gave them a lot of ability, so they can learn from the book and they can learn from CyberPatient or from anything. But the other 90% would be greatly supported by CyberPatient. So other study that we have done at UBC here showed that CyberPatient is no different than the standardized patient, but it's 90 times less costly than standardized patient. And also the study in Kazan State Medical University showed that about 90% of students believe that their performance, the impact of CyberPatient, their performance was significant when they were going to the hospitals and dealing with patients. There are plenty of evidence on decision-making scales of nursing that was published also. But the most interesting one here, one of my PhD student from Bulgaria, he is a pediatrician, and he did a comparison of CyberPatient, classical clinical teaching, and also a high fidelity simulator. So he compared all these three groups. His objective was to look at the memory retention after 2 months using different methods. And he found that CyberPatient was significantly higher memory retention than high fidelity simulator and classical method of teaching pediatrics. And it will be published perhaps in the next 2 months. So people may ask me, why would CyberPatient be superior? What's the mechanism of impact? What's behind it? There is actually enormous amount of literature that shows that a virtual simulation, particularly effective because they are hands-on and they have an active engagement of students, because you have, according to Avogadro's theory of multiple intelligence, so you use every aspects of the memory, visual memory, tactile memory, reading memory, and others. It's also very important. Research has shown that spaced repetition is very important for memory retention. And CyberPatient is as a tool that provides spaced repetition for clinical work, what you cannot have it with patients. It's good for transfer of learning, as we discussed, and will build semantic networks in our hippocampus. And also motivation. It motivates because it's a gamified version of learning, so that the students are very much motivated. And also, as we said, it improves recall, recognition, memory. And there is huge number of papers that actually proves that a virtual simulation can be translated into real life. So there's nothing new here that we are saying. We're just summarizing what in the international literature is already proven. Having said that, just maybe Mark talked to you about it. I'm not going to say a lot, but I can just say that CyberPatient is very useful for students. It's beneficial for faculty. It's beneficial for healthcare system. It's beneficial for educational institution and regulatory bodies also. We're working together now with the Royal College of Physicians and Surgeons of Canada, many other regulatory bodies to use CyberPatient for the accreditation purposes. So at this point, I apologize if I talk too much in the end of your presentation, but if you have any question, I will be more than happy to entertain. Thank you.
Thank you very much, Professor Dr. Kayomi, for the very insightful presentation on competency-based medical education. And we can see that CyberPatient as a virtual hospital has moved very far from the classical learn one, do one, teach one that we used to do, yeah, Prof, which affects patient safety greatly. So with CyberPatient, and like what Prof has mentioned, there is spaced repetition that leads to mastery. And again, it's engaging because it's gamified. So it's really a very beneficial e-learning platform. So we're happy to take questions or comments from anyone. Please raise your hand and we can unmute you so you could raise the question, or you could type your question in the chat box. Any question from anyone? While waiting for questions, perhaps Professor Kayomi, may I ask you a question? In your opinion, specifically for the Asia-Pacific region, what is the potential of the use of an online simulation like CyberPatient in the next, say, 5 to 10 years post-pandemic? And what is likely to be its role in medical education?
Well, I think CyberPatient is a virtual platform. Let's talk about virtual platforms entirely. For competency-based education, for clinical experiential learning is something new. If you remember, like about 20 years ago, e-learning was something new, and people were like, oh, what is that? I like to read my book, what is that? I don't want to touch that. And now, like, e-learning is an integral part of every university, every human being. And the old people like me, old dinosaurs, that slowly die and they go away and they leave the environment for people who are digital natives. So what I'm saying is that the virtual environment for practice of medicine is something new. It's not perfect yet, of course, but slowly the technology goes into perfection. So I think because it reduces the cost of medical education and the cost of healthcare system, particularly in developing nations, it will be a priority for people because it's economically sound, right? And also the other important thing for your region is that how much money do we spend to get North American standard of education, going to conferences, inviting speakers, doing this and that, sending a person for 6 months to a hospital in Harvard University or UBC or McGill or somewhere. It's enormous, right? While now with the help of technology, you don't have to spend that money. You don't have to go anywhere. You can bring them to your home. You can bring them to your university the world is getting smaller. That's what my passion is. My passion is to equalize the medical education between developing and developed countries. Because when I go to some countries, I do a lot of charity work in a lot of countries, and I see that their curriculum is based on notes that was done 10 years ago by somebody, or books that are already, outdated. You can't just improve that. It's impossible with the economy of the world going downward and so on. But with virtual platforms, now the electronic platform for theory is already there. Now we're bringing virtual platform to do the competency-based education. Of course, in the end, you have to go to a hospital and see a patient. Without a patient, you cannot be a doctor or a nurse or anybody. But this, so what I see for your region, to answer your question, two things. One is that equalization of medical education and bringing actually state-of-the-art medical education to your doors with very little cost. And that's what I think the future of medical education.
Thank you very much, Professor. Yes, you have answered the question perfectly. We have a participant with a question. Dr. Iliana, you may unmute yourself to ask the question.
Hi, thank you. Okay, I'm Iliana from Malaysia. I would like to ask, in future, how fast would CyberPatient aim to add on more patients? Do you have a projection like 100 patients per year or anything?
Yeah, at this point we have 130 patients, but according to the word classification, there are different classifications, but the one I respect very much is 1,600 classified diseases. In the world, there's lots of variation of those classified diseases. It's 1,600 classified diseases. And but in medical schools, we don't teach more than 140, 130. So, but that is not our intention to bring all those diseases, but our intention is to partner with universities that we're gonna work together to bring diseases that are specific to those countries. So if we are going to increase, we are going to increase some. We're going to we're going to do another 100 diseases that are North American based. But if I want to do more than that, it would be all diseases that we don't see in North America. So diseases that the world is suffering from, but it doesn't bother us. So we want an international platform, and that international platform should serve the international community. That's why we are putting some, when we sign a contract and university subscribed, we put some of that money back for research to support the young faculty to do research. And the research is mostly based on whatever they want, but one of them is to develop diseases that are specific to that region. Having said that, CyberPatient is just the tip of the iceberg. We have 7 other products in the pipeline that would address the other problems of medical education. CyberPatient, as I mentioned, it builds a bridge between theory and practice of medicine to fill the gap between theory and practice. But there is another major gap in medical education, and that is the individual training and team performance in the hospital. We have nurses individually trained, doctors individually, respiratory therapists are individually, social workers, everybody. But when they come around the patient in the emergency room, they have to work as a team. And seldom that team doesn't communicate. There is no communication dynamics. And that harms a lot of patients and costs a lot of money to the universities and to the hospitals mostly. So nowadays we are using physical simulator, and around physical simulator, we form a team and we do the pre-briefing and debriefing afterward. But it's very expensive because those mannequins are expensive. Then the room you have to have for that. Then you have to have trained people to take care of that mannequin, train people to develop the curriculum around it. Then you have to bring the nurses from the ward. And I don't know how in your countries are that, but in my country, in Canada, when I'm inviting a nurse for an education session, I have to pay for another nurse to work for her there. So it's called backfilling, right? So I have to pay for backfills. So it becomes very cumbersome. And how many we can do? Maybe 2, maybe 3 the most per day cases of simulation for team training. Now we developed a new product that will be released by the end of this year that you have an avatar patient inside a 3D OR, a 3D avatar, and a teacher or an instructor is in full control of all vital signs, heart rates, blood pressure, everything of that avatar, and can communicate with avatar. And then you have the team members, the avatars for the team members that are controlled by a real person from outside. And they all go from different part of the world. They don't have to be in the same place, can go into this ER and act upon that patient and treat that patient and go debrief later on and learn from their mistakes, like what they did wrong and where the communication was broken and what they didn't do and what they should do next time. Aside from that, we have also CyberPatient for the CME, for the continuous professional development, the CPD. So for maintenance of competency. And actually, we are one of the rare companies who received major grants from the Canadian Space Agency to build a CyberPatient system for long-term flights, in long missions, to 10, 20 years mission to the deep space. Because when the crew is in the spaceship and they go for a long time, they don't see many patients, so they forget what they learn on Earth. So they want to use CyberPatient so that they can practice while they're traveling into the deep space. And in that, to answer your question more precisely, for maintenance of competency, we're gonna do maybe more than 600-800 cases, because we are gonna build wards. Right now, we're building a burn unit, a ward with 25 people, and also we build another ward, not ward, but a clinic for lactation consultation, for example. So we do have lots of, we also have CyberPatient for communication. We're building CyberPatient for communication, delivering the bad news, transferring the patient, all those kind of things that you can do in the hospital. So we're trying to, instead of increasing the number of CyberPatient in this particular one, which we could do, we are covering other problems of medical education in bringing the scope of the work of CyberPatient into others, areas. I hope I answered your question.
Yes, thank you, thank you.
Most welcome.
Thank you, Professor. Any other questions from the floor or any comments? No? Feel free to contact our team if you have any queries regarding CyberPatient after this. We do have a couple of engagements that we do with everyone in the faculty. we have trials for interested parties to have a look. We can open up things like a dummy class for CyberPatient, and faculty or students can have the opportunity to evaluate a couple of cases, perhaps 3 to 5 cases. The number of students are unlimited, or you can choose to engage in a data-driven trial to properly look at the value of CyberPatient and how it can help your faculty in terms of training medical education. And very interestingly, Professor Kayumi has mentioned that newer programs are coming up, like the interprofessional education, where everyone can kind of online and practice together from different locations. That sounds really exciting and interesting, and that definitely will improve patient safety. I'm aware of the time, so if there's no further questions or comments, thank you again very much, everyone, for coming and joining us. Let me just share our contact. So if anyone is interested to follow up, you can find us here. Let me just. So, sorry, not this. Mark, do you have any closing remarks to say?
Yeah, thank you so much. I appreciate that, Dr. Olivia, and thank you, Dr. Kayumi, for taking time this evening. Thank you to everybody who's joined in. It would be our absolute pleasure to engage with you if you have any questions, you need any support, if you'd like to further evaluate the interface. As Dr. Olivia mentioned, we're happy to create a sample class that you could join in as a student, or perhaps just if you want to register at cyberpatient.ca, you're welcome to do so. And we look forward to supporting you and working with your institutions.
Yes, thank you, Mark. So alternatively, if you would like to contact us at iGroup, you could email us at marketing@igroupnet.com, or you could contact your local representative. Like in Vietnam, we have Ms. Lan. South Korea, we have Tony. Indonesia, we have Patrick. Singapore, we have Tom. Malaysia, we have Kali. So these contacts are available. So do contact them if you are keen to follow up with CyberPatient. So I think we could end the session. Thank you very much again, Professor Dr. Kayumi, Mark, Nikki, and everyone from the team. Thank you very much. We'll keep in touch.
Thank you so much for your time.
Thank you. Have a lovely day.